Assalamu alaikum and good evening, respected physicians. After a long gap, we have started again our endeavor of this educational program, ECG Basic and Beyond, organized by ECG Study Group. And today, we have amongst us one of the favorite teacher, Chowdhury Ahsan sir. And before delivering his speech, as usual practice of our program, I'd like to request Prof. Abdul Jamil sir to say some words regarding Chowdhury Ahsan sir. Jamil sir.
Thank you, Tushar. Assalamu alaikum. We all know about Chowdhury Hafiz Ahsan Bhai, and he's a great teacher. We learned a lot of things from his each speech, and he can deliver everything very interestingly, especially the ECG and correlation with the clinical and angiographic features. I don't want to kill more time. I ask Hafiz Bhai to start his lecture, please.
Okay, so সবাইকে অনেক অনেক ধন্যবাদ, কারণ এই লেট নাইটে রাত জেগে ইসিজি এই পোকা ওয়াদুদের মাথায় আর আতার ভাইয়ের মাথায় ঢুকছিল, তারপরে আমাকে আর রফিক ভাইকে, এখন আজিজ ভাইকে। তো আমাদের এখানে সকাল, আপনাদের এখানে অনেক রাত। তো আমি আজকে ইসিজি ইন্টারপ্রিটেশন, আমার সাথে তুষারের কথা হয়, তো আমি চেষ্টা করি এই ধরনের কন্ট্রোভার্সিয়াল এরিয়াতে কিছুটা হাইলাইট করতে। তো লেটস সি। সো because it is a challenge when a non-cardiac surgery is on the way, then we encounter a patient and it becomes a challenge. So this patient, for example, was waiting, is waiting for a gallbladder surgery and then went into this rhythm. Any comment? The way I look at this, that this is like tachycardia. This is white complex tachycardia. This is regular tachycardia. And question is, what are the differential? And how the patient is doing hemodynamically. The one reason I'm tagging this along with the surgery on the way, because before and after surgery, non-cardiac surgery, there is implications. So anyone to jump in about how to proceed from here?
Hafiz Bhai, I want to comment on the rhythm strip at the bottom.
Yeah.
It seems to be a little bit irregular. Not
Some
exactly
irregularities, but pretty much, I'm not an EP guy, that's why I love to have Rafique Bhai. Even in VT, you can have little bit of irregularity. But
Yes.
let me show you this. This is we don't have any Nepalese students. I don't know, because they are very good in looking at the strip speed. This is at 50 millimeter per second. And you can see that there is the depolarization is fractionated. And now I have an EKG that look at the lead one. Do you think that the second beat and the fourth beat is a PVC? If it is PVC, then in VT it looks like that. So the PVC and then the white complex tachy, the morphology is same, then it is one of the powerful indication that this is VT.
Yes.
And they were thinking about this EKG, that, well, can it be WPW? And then they gave proconamide, it broke. But the problem is, this patient has gallbladder on the way. EF is reduced. So we had to do the angiogram, and after the angiogram, we fixed the RCA and the LAT. The question now becomes what to do with the gallbladder. So, we always can talk to each other. They put a drainage tube, and then they will do this after like 6 weeks to 12 weeks later. So I'm bringing this issue up because when there is a non-cardiac surgery on the way, we are worried about the perioperative complications and also, for that matter, intraoperative complications. In my experience, and Aziz Bhai is here, is basically a dialogue to happen between the cardiologist and the anesthesiologist. And then the surgeon, of course, is in the picture. Actually, the anesthesiologist is kind of the wife of the surgeon, because whatever you tell, the anesthesiologist will later tell the surgeon, don't take it, don't take it. And the surgeon will listen to that. Anyone, any comment about that? How you see the interaction between the non-cardiac surgeon and the anesthesiologist? And for that matter, the cardiac surgeons also like that.
But to our okay. In Bangladesh perspective, if things are a bit different, if a cardiologist says that there's a problem, if you go for non-cardiac surgery before correcting the cardiac problem, very few surgeon goes for surgery. So because of many, if the patient develop a complication during surgery or after surgery, so they want to be in a safer side, and this is true for bigger cities. May not be true for
we lost you. So you are saying that in Bangladesh, the cardiologists are more conservative than the anesthesiologists? Because
no, sir.
I can tell you.
No, I think the other way around. Yeah.
I'm saying cardiologists, the opinion of cardiologists are valued much more.
Yeah, it is. That is everywhere, right? So we, as cardiologists, we need to understand the whole spectrum of the disease process and whether it is okay, a reasonable risk to take to go through the surgery. And we all go through that algorithm, right? Is it emergency surgery or urgent surgery or elective surgery? Because or semi-elective. So emergency means life-threatening, needs to go now. In that case, we only hold their hands and tell them that we'll be with you. Example, there is a femoral arterial laceration and the EKG changes suggestive of MI. Which one you do? Still the bleeding. This is the extreme example. Dire emergency, that has to be taken care first, right? Second one is the urgent. That means the patient cannot wait more than 24, 48 hours. Example, hip fracture, significant morbidity and mortality if we don't do this. That we are participating in the study called hip attack, so that a variety of reasons, there is troponin and injury and troponin or EKG changes. These are elderly patients, comorbidities. Can we still say that it is reasonable to proceed? Reasonable means it can be high risk, it can be low risk, or it can be what I call it prohibitive. That means the cardiac optimization needs to be first. And in this case, for example, the patient is in the VT or in the ventricular tachycardia storm. We need to address this first. So let's hold on this thought. Before I go to the general discussion, any comments by Aziz Bhai or Wadud or Jamil?
Now, I think you clarified those things, that how urgent it is, what is the risk benefits. If it is truly urgent, we normally just stabilize the patient. Sometimes, if it's a very urgent surgery for this particular patient, in the settings of VT, probably we might let him go for the surgery with amiodarone, perioperative management. And if necessary, some anti-ischemic regimen on board if you suspect that ischemia is on the cause. But we'll let him go for surgery if it's truly urgent surgery.
Right.
Otherwise,
and it is important in relation to a non-cardiac surgery that we pay attention to ECG to start with. Always, everything in clinical medicine starts with the patient. And clinical context, clinical context, clinical context. And then find out whether there is any arrhythmias, any bradyarrhythmias, first degree AV block, right bundle, left bundle, bifascicular block, the potential for bradyarrhythmia or potential for tachyarrhythmias. And then the ischemia is the fear, and it is a rational fear or irrational fear. And then the question is perioperative time. We need to be careful. There will be, hemoglobin changes, electrolyte changes, the intervals may be changed, or the ECG may be the first reflection of structural heart disease, such as voltage criteria for LVH. There may be low voltage. There may be, IVCD. The patient may have a pacer, may have an ICD. That can be a reflection that there is underlying pump problem or valve problem. So, in summary, we need to look at the heart in the clinical context, electricity, plumbing, valves, and pump, and the hemodynamics. And a lot of things will change during the surgery. There is vagal thing, there is adrenaline surge, and then there is sympathetic surge giving this along with the fluid shift. But Rafique Bhai is not here. The fundamentals of tachyarrhythmias remain the same. That means it may be an automaticity. That means there will be spontaneous depolarization of the subsequent conduction system other than the sinus node, and that can trigger, I should not say trigger, the automaticity is the mechanism that can start an arrhythmia. The trigger is another way of doing this, right? The re-entry automaticity and triggering, the triggered activity, and the spontaneous depolarization other than the SA node early on can give you the automaticity. And the triggered, the preceding depolarization can alter the depolarization for the next beat, or channelopathy, or precipitation of new electrolyte imbalance, giving channelopathy and giving you a triggered activity. And the other one, the traditional, more conventional way to understand most of the arrhythmias can be the re-entry. Whatever it is, in non-cardiac surgery context, we need to understand the patient-related factors, anesthesia factors, the surgery factors. The cardiac diseases pre-existing, previous AFib, more AFib. Previous arrhythmia, more arrhythmia around surgery. And then the autonomic nervous system also can be a big issue. And then the more older patients we deal with, and this is a challenge for us because I gave you an example of hip surgery. We try to do this within 48 hours, preferably within 24 hours. And it is a really hard to evaluate this patient who has a lot of comorbidities, old age, and they don't do well. So anesthesia is also important. And one of the things that the anesthesiologist, I don't know anyone present here, is the presence of LV dysfunction and then aortic stenosis, particularly critical aortic stenosis. However, it is not necessarily prohibitive, but they need to take care of these factors when they induce with anesthetic agents. And then there is the change of hypoxia precipitation, and then pre-existing COPD hypercarbia, that can be an impact. And then the surgery related factors, particularly when we are doing carotid surgeries or dental surgeries or maxillofacial surgeries, this can have profound autonomic nervous system impact. So whatever this is, I'm not going to waste time. I want to show some cases. Arrhythmias, is it tachy or is it brady? Is it narrow or is it wide? Is it regular or is it irregular? This is pretty much medical school type sort of algorithm, but it is good to follow this algorithm and then have a clear path and then assess the patient's hemodynamics, patient's underlying rhythm, and ask this question always in the back of your mind: how did I come here? Who is the patient? How this happened? Because most of the time, not always, most of the time, if it is something after this, it is usually because of this. Oh, Rafique Bhai just joined. So Rafique Bhai, stop me if you have any comment. So bradycardia and tachycardia, and then it is easy. If the patient is, if there is a wide complex tachycardia and I don't have any EP person near me to figure it out quickly, then I pray. The patient can pass out, I can shock. That makes it easy. But if it does not shock, if patient is not passing out, then you have to evaluate that it is most likely a regular wide complex tachy. Is it with SVT and aberrancy, or is it a VT? And there are other differential as well. And these are the things in our armamentarium for the bradyarrhythmias and the lower few drugs we use for the tachyarrhythmias. But I would tell you that some of the drugs that we often like to use, like diltiazem, and then the esmolol, we need to make sure that we have a good sense of the patient's pump function, because diltiazem often with AFib, with a compromised ventricle, you can decompensate. So let me present this case. This lady fell, had a hip fracture. And as I told you, we have a robust hip surgery program, and they really on our nerves to get these patients cleared for hip surgery. So what will you comment about this patient? This patient had this EKG. Any comment? This is normal speed, and this is the EKG. Rafique Bhai. And then the patient was doing this. I don't know, Rafique Bhai is muted. And then patient did this. So wide complex tachy still was retaining blood pressure. Any comment?
Sir,
Can you go
can we go?
first ECG?
Yeah.
Yeah. Okay.
And then this happened, Rafique Bhai.
Electrolytes good.
So like, yeah. Okay, I like this. Rafique Bhai does not watch cricket, but when there is a review, you wait and they say, go to the next one.
How about
Asif Bhai, you are enjoying.
were the electrolytes good?
electrolytes is not good. But
look at the QT on the first EKG. Let's
Yeah.
yes,
One
QT
QT.
is prolonged. Yeah.
It is prolonged.
That's
Yeah.
that's the
That's problem there. Yeah.
So this, and then I found this most valuable thing, but after a day, that there was pauses, and then there was like this. Rafique bhai?
Yeah, but what are the potassium, sodium, potassium, magnesium?
Okay, so LV function was normal, and this happened, and the potassium was corrected, magnesium was corrected, both were low.
But corrected before the surgery or?
No, corrected after this rhythm taken care of.
Oh, okay. Yeah. Well, I mean, the issue is that the QT was long, so the electrolyte probably was contributory because the VT is difficult to explain by electrolyte abnormal. The VF can be, especially with pauses.
So this, when we corrected this, and the ortho saying that, hey guys, this is high risk, we should not do this. And then anesthesia says, I'm not going to touch this patient, as if the patient becomes like Indian schedule caste. So what we say from cardiology, that it is okay to go or no? Is it high risk or it is prohibitive?
You were telling that the patient have relatively normal hemodynamics despite the arrhythmias.
Yes, patient is okay. The tricuspid regurg was recorded as moderate, but I would say that it is moderate to severe TR. RVSP like 70, Wadud. And then LV systolic function is preserved, and I would not call the mitral rigor severe. Probably I will call it moderate, and there is no other significant wall motion abnormality, no other valve problem. And no prior cardiac history, no stroke TIA, and no kidney problem. So I had to compromise because I thought the patient is high risk but not prohibitive. But I gave in. The anesthesia was twisting my arms. How do you know that this is not like significant coronary disease? So I cath was negative. Patient went for surgery and did okay. So so it is a multidisciplinary dialogue, and I request you that we quickly have a group chat or a multidisciplinary teleconference. And I tell the mid-level like fellows to get everybody on the phone so that we can have a quick decision making. And honestly, the patient family understands this risk, and they were agreeable to proceed, and the patient did okay.
Can I make a comment?
Yeah.
Yeah. One of the things I always wondered about potassium, like if somebody is hypokalemic, let's say potassium is 2.6,
Yes.
and we give potassium, I check the level.
Yeah.
I think there was a time one of my friends did some research with total body potassium versus the serum potassium. There can be a lag between the two.
Yes.
That's correct.
And that's the problem with this. And so, I mean, but if somebody needs surgery, they need surgery. We have to get it done.
Yeah, and this is exactly, Rafique, but that we replenished potassium, and then we did the cath, but we told them to still keep the patient in the list maybe later, but don't take the patients off the list. So this how we assess these patients. This is a 43-year-old obese lady and type 1 diabetes, and interestingly had some uterine surgery about a week ago, and then progressively getting worse, and then presented with this EKG. Any comment?
Definitely, it's one of this, STEMI mimic that we need to always look at it. Diffuse ST depression and ST elevation in AVR, and in the real clinical setting, you have to be very careful of this left main disease or
this is exactly right.
Yeah.
And as Aziz Bhai pointed out, that the patient also was congested, pulmonary edema, had an ostial left main that we needed to fix. And the patient did fine. We used the supportive device. However, this is interesting that probably God challenged us with this. This patient came in with this fever chills for a week, and this EKG, and then this is the chest X-ray. I could not get the echo uploaded. When we saw this, a bedside echo showed that there is aortic valve, large vegetation, and there is mitral regurg as well, and suspicious vegetations in the mitral valve. But the aortic valve vegetation is large. And this EKG, this chest X-ray, and this EKG. So the patient needs to go to the OR because we cannot stabilize this patient. We cannot give any mechanical circulatory support. And the patient was deteriorating. And then surgeon says, he's 64. How do you know that there is no significant coronary disease? And they wanted to stabilize. I said, how to stabilize? And we actually did a CT chest and then proved that there is no significant coronary disease. So I think these are the things that come into play that when you interact. And my question is, as Aziz Bhai pointed out in the last case, that the AVR ST elevation and diffuse ST depression, this is not in the criteria for the STEMI activation, but it may be like a STEMI mimics and has to be in the consideration in the right patient with left main and ostial LAD. But in our patient, what do you think the likely cause of this global ischemia and then EKG changes?
And the question right now, how large this vegetation is, you mentioned large vegetation and what area of the vegetation, what coronary cusp was involved, whether it was obstructing any blood flow to the left main. That's another concern I have in my mind. Okay.
Yes.
Or anything that went, sometimes it can go, but it would be distal immobilization with the vegetation if it's very close to the coronary cusp, the left cusp.
Right. But what I'm saying that sometimes you can see these changes of the AVR ST elevations and global changes following SVT, following nasty arrhythmias, following exercise testing, and some, particularly those with LVH, and they may not have an underlying significant left main or prox LAD. And in other situations, such as when there is a rapid increase in end diastolic pressure, you can see this kind of EKG picture. And in this case, I think the patient was in aortic regurgitation and mitral, and then EDP was so high, and the aortic diastolic pressure came down because of the AI. So this perfusion pressure in the coronary was almost non-existent. And that can be giving you this. Yeah. That is a very likely explanation. So let me share this case. 74-year-old Korean woman with ovarian cancer. Chemo started a month ago. They were trying to do debulking and awaiting for gynecological surgery, and then presented with this EKG. and in the hospital, they are ready to go for the surgery, and this happened. So tachycardia, and then every other beat is different, and it is wide.
Seems to be Bijimini pattern.
And this is the EKG that we found before she went into this.
That's a bidirectional VT. Looks.
I don't know, Aziz Bhai, whether I will congratulate you or not, but because we can be wrong, you can be wrong. We actually thought that this is bidirectional VT. And what we did after the VT, we looked at this EKG and it became like that. And then everybody's saying,
okay.
But this EKG actually normalized without going to the cath lab. And then ultimately we went to the cath lab. I don't want to bore you because we had to go. Even the EKG normalized, the troponin came back to 50,000. And the anesthesiologist was telling me, are you kidding me? That you are not going to the cath lab. I'm not going to go to the OR with this patient. Remarkably, the LV function was mildly reduced but global. So before I actually went to the cath lab, I showed this to the anesthesiologist. And this is the graph I showed. And I think we all should remember this. Look at the troponin business. Troponin is not a binary thing. So 50,000 troponin in the 5th generation is equivalent to what you are doing in Bangladesh in some labs is 4th generation, it is 50. So 50,000, if you look at the vast majority of the troponin confusion, it can be type 1 MI or it can be type 2 MI. I don't need to explain this to this audience, but it is not binary that you rule in MI, rule out. It can be non-ischemia related troponin like trauma, like sepsis. Those are not MI. But if it is hypotension, hypoxia, COPD, hemoglobin 5, those troponins are mini troponin, or I call it small troponin. These are less than 1,000, less than 1, or less than 5. But when it goes to 20,000 or higher, then you are talking about, the big things like large MI or myocarditis. Above 50, there is nobody else there. Only two things, myocarditis or type 1 large MI. So therefore, and then when this happened, before I went to the cath lab, I was absolutely sure that this patient will not have any coronary disease, because this is the evolution of the EKGs that happened following the tachy. And this is the shoulder down, kind of Brugada type.
Brugada.
And these are not usually the real STEMIs. Okay, so this patient had we need to all be aware that this is the newer oncology drugs that can give you nasty myocarditis, and that was the case in this case. The pembrolizumab.
I have one question about normally in the myocarditis. We don't see that much of ST elevation. Normally, I'm just talking about more like non-specific changes or tube inversion or minor ST changes. But that huge ST elevation, I'm not sure how to explain that.
Yeah. So, and I failed to upload one images. I could have convinced you. when you give any shock or you give any sympathomimetic drug, it can give you this problem as well. Even after PEA arrest, when we give epi injections, sometimes
that can do that, yeah.
Yeah. And
That's
I wanted to show you
high
the
sympathetic drug.
exactly. And I want to show you the CT of the chest, which was done for this patient later, and the coronaries are okay. And we did the coronaries anyway later. I could not convince the anesthesia and the GYN doctors that the CT was reasonably okay to say that left main and LAD was fine. I had to do angiogram, and I would not argue for a diagnostic angio. So this patient, kind of interesting, 76-year-old, hypertension, dialysis, present to the hospital after a VFib arrest after dialysis, and ECG after resuscitation. By the way, the patient was waiting for her fistula to be revised. And anesthesia was involved because it was complicated fistula revision. So we had this EKG, and then after the potassium and magnesium correction, patient's EKG came back to kind of a civilized way, and then corrected electrolytes, and an ECG later was good. And then the patient received temporary wire, corrected the potassium, magnesium, and the patient went like the other patients with the polymorphic VT that stabilized and also got this fistula revision. But sometimes we invite troubles. And let me tell you what I mean by that. This patient is a young patient, had a fall, ankle fracture, and I don't know why they did a troponin. I have no idea. And some of you. So, Aziz bhai, do you have any comment why they did troponin?
I have no idea, but normally it needs education in the emergency department because they routinely do EKG and troponin, and we tried hard in MRA to really teach them.
To make it worse, after the troponin, they did this EKG.
Okay, so
Hafiz bhai, in our hospital and also while I was in Square, the ER people made the troponin a routine investigation for any patient. No cardiac symptom, no chest symptom, they are doing troponin routinely. And mildly raised, so it is MI, take this patient. Yeah. But the patient came with septicemia.
Correct.
Yes.
And you know that the hospitals love it because they call it MI, and then the billing code goes higher. And when I tell them that not only you are billing wrongly, if the patient dies because of sepsis, that becomes my death, MI death. So you are, so that is actually, and you need to look at this because when you are publicly reported, like our hospital, it is actually a problem. It can give you bad reputation. I don't want to take any ownership on something that I did not even do. So how do you tackle now?
This early report on this patient.
Yeah, so absolutely. It's early report, and then to convince them, I did the echo, and then I tell them that transmural injury will give you some wall motion. LV is absolutely normal, and then then what happened? The anesthesia said, okay, it is not hip attack. It is not elderly young guy. Let's wait. We waited, did another EKG, convinced them, and then the patient went to OR. And then this
and
is...
I like to make a comment, Dr. Ahsan. We need to really think about anything with a diagnosis, always think about what is the pre-test likelihood the patient might have problem. Clinical thinking, because this is a 31-year-old gentleman, no chest pain, came with ankle fracture. And is there any reason to do the troponin? And if you find something on the EKG, what's the likelihood the patient really has acute coronary syndrome or just early report on this patient? So that's the way we need to explain
up another good discussion point. Since you mentioned, let me tell you this, because we have extra cautious physicians also, and the fellows, they like to bring up issues. So they said, I don't know, Dr. Ahsan, can it be a SCAD? If it's not an atherosclerotic coronary dissection, it may be spontaneous coronary dissection without any coronary atherosclerosis. And I said, yeah, good point.
But no chest pain.
Can it be? And then I told them, can it be aortic dissection going into the coronary? And then I tell them that, look at the patient. The patient is watching CNN eating banana, and the patient has problem with ankle fracture. So it is statistically less likely. However, you can look at the chest X-ray, you can look at the aortic root, and then you can look at the AI, and then you can look at the wall motion. Then you can, and then if that does not solve your problem, then you can follow the rule of medicine, like tincture of time, little bit of weight, everything pans out good. Okay, go to surgery. And we did. I hope that that assures you. And sometimes it is better to have a precautionary note and evaluate patients properly. And I tell you, this is a 70-year-old male. It happened in the last weekend. And I swapped my call with somebody last week. And in the morning, this patient comes in. He's our own anesthesiologist in this hospital. He had a prostate surgery 5 days before. And by the way, he had a cabbage 2001. He's long-standing type 2 diabetic, hyperlipidemia, hypertension. And the anesthesiologist had this TARP done. And I asked him, did you have any pre-op evaluation? And he said, no. And he comes in with this EKG in the morning. He woke up early morning, was not feeling comfortable, took some antacids and was convincing him that he's okay. But then the wife said, you don't look good. And then this EKG. Any suggestion? Okay.
Yeah. Do you have any prior EKG on this patient? Otherwise, definitely the subacute phase of the MI that I see, in inferior subacute condition, and also there's some ST depression, V1, V2, V3. The posterior involvement may be subacute phase.
Okay. And then this patient, we took the cath lab because there was a STEMI, and question is that this is Wadud's favorite question, that what territory is the culprit? Patient had cabbage in the past. And if you look at the EKG, I don't know, Wadud is still here.
I am.
And this is and this is actually important, because I remember this thing, because sometimes STEMI is a T20 game. For variety of reason, the ER is slow to activate, and you have only 10 minutes left, and you rush to the cath lab, and you go with the guide to save the time. I have cases where I just got the total balloon 89 minutes. And so what guide we should go after? But it is interesting that this was more in 2-3 AVF, and there was more in AVL, V5, V6. So this was the Lima. Lima is good. And then this is the RCA. You can see there is a high-grade stenosis, but I did not go up with the guide because I checked the circ first. And this is the circumflex was the culprit. And look at this. After the balloon, the circumflex became very good because it was basically occluded. I don't know, you can see this. It was no flow in the circ, no flow. And then after that little balloon, the beautiful flow. And then we did the balloon stent and all that. So what I tried to do in last 45 minutes or so, that we encounter a variety of problems in patients who are going for non-cardiac surgery or who had non-cardiac surgery, or you may be waiting in the hospital for non-cardiac surgery. And the complications rate, if you think about this, Rafique bhai is still here, the vast majority of the cardiac complications are actually arrhythmias. About 35 to 40%. In some studies, it can be little over 50% complications are from arrhythmias. Bradyarrhythmias, majority of them are tachyarrhythmias. And number one, as you deal with the older ones, is atrial fibrillation. And those who had arrhythmia before, they are more likely to go to arrhythmia after. Overall complications in terms of ischemic events or precipitation of heart failure is going to be in the range of 1 to 5%, depending on the what population we are talking about. You may think, some of the younger guys in this audience, you may be thinking that that's not a big number. But I warn you, it may be 1 to 5% overall if you are looking at a 50,000 population score. But the problem is, once they are in the type 1 MI, the mortality is skyrocketing. It actually 3 to 5 times higher mortality post non-cardiac surgery patient for a variety of reasons. So therefore, it is important to evaluate these patients very carefully and before you deal with them. And we also need to be careful about the anticipated problem that is coming, because the surgical house staff may be giving too much fluid. There is hypotension, and only thing they can think of is fluid, but there may be something else causing the hypotension. And remember that famous equation, blood pressure is equal to cardiac output times SVR. And always think, am I dealing with a low cardiac output or low stroke volume, or I am dealing with a high SVR? Am I dealing with sepsis with low SVR? So it is very important to understand the hemodynamics and then address that way in a perioperative period. But best thing is to be vigilant, and for elective or semi-elective patients, we need to be very careful about how we evaluate them before they go into non-cardiac surgery. In high-risk population, we need to have an interdisciplinary dialogue before and after. And we should have the anchoring physician, which I always believe is the mid-level, who can connect the big guns, meaning the attendings quickly, and say that, hey, I have a problem with this patient who is going into surgery or is immediate post-op. What do you guys think? And it is important. By the way, my patients with the anesthesiologist who had a prostate surgery had a Foley. And after the nice, beautiful results, I was called in because he was getting hematuria, right? So I have to call the anesthesia, the urologist, and saying, I'm not going to do the omission of, stopping of the DAPT. Can you help? And then he did the bladder irrigation, and he was more confident than I am, saying that, you know what, the TARP is good. You may have precipitated, but I am good that it will go away. After about 12 hours, the urine was clearing. We did not need to stop the DAPT, and he had an uneventful course subsequently. So it is important that we have a interdisciplinary dialogue. And please do not let anyone take the decision alone. Imagine that if I did the DAPT, MI, and the nurse calls the urologist, he comes in and sees the hematuria, frank hematuria, and stops the DAPT. That will be a disaster. So these are the things that we need to be very careful. And I tell you one thing, we are very good in screwing up things in the hospital. Hospital is a bad place. And it is bad because we don't communicate with each other and we don't work as a team. So I will stop there. Thank you.
And I'd like to make a comment on that, because most commonly the question arises that what to do if you put some stent or if you do intervention in the coronaries, then dual antiplatelet therapy, we continue to do that, at least, current guidelines that we have. But the question arises that certain surgery, even you need to talk to the surgeons. If it's semi-urgent surgery or something, they can still go, and certain surgeons feels comfortable that to do the surgery even with the plastics on board, as for example. So you need to really have a good discussion with the team. Other way around, as for example, like we had a patient, I'm giving an example, that was found to have, came with ACS and was found to have incidental, like huge renal mass, okay? And the patient it has to be removed. That's highly suspicious for renal cell carcinoma. We went in, and then we ended up doing just plain old balloon angioplasty with a drug-coated cutting balloon, and we didn't put the stent. And then we allowed him to have the procedure done within 2 to 4 weeks. Actually, he had it done, and he's still doing okay. But this type of certain manipulation probably could be done in conjunction with talking with the team. They have to work together, and what's the best approach for this particular patient. All right.
Was that Aisbhai?
Now, I'm not sure whether you listened to my conversation.
Yes, I did not,
Okay.
because I got a text about a patient who is going for they want to know the EF. Yeah.
No. The two points I wanted to make, that both way we need to have a team, like surgeons, anesthesiologists, and cardiologists that you mentioned is important. What's the best management for these particular patients? How urgent the surgery in the settings of ACS? One option that we just did, I give an example of one of my patients came with ACS, found to have big renal mass, and is highly suspicious for renal cell carcinoma, and the patient's family is very eager to take it out. Okay, what approach could be? We decided, as for example, we went in, did the cap, because it's very had troponin elevation, dynamic ST change. We had to go in, and we decided not to put a stent. We decided to just OM branch, just to the angioplasty with drug-coated cutting balloon, and just a plain old balloon angioplasty, and leave him alone. And then he had it done within 2 to 4 weeks. Within 4 weeks, definitely could do that. But if the thing that needs to be done, even after 2 weeks, we allow him to get the surgery done. Because another thing that I mentioned, that some surgeons feel comfortable, certain surgeries, to do on plastics. As for example, some amputation, they can do it. Even I found some patients' memory, some surgeons could do breast surgery with the plastics on board if they need to. I'm just letting you know it is evolving, and we're getting more data on that. So it's an interdisciplinary approach is more important in this case. What to do with the dual antiplatelet therapy immediately after ACS intervention, and what kind of intervention would be appropriate for this particular patient, depending on how urgent the surgery is.
Yeah, good point, Asif, because we deal with these kidney transplant patients, and I do the pre-op, and I said that I don't want to stop the DAPT until at least 3 months, mandatory, preferably 6 months, if coming with some complex cases and all that. And because of the endothelial healing and endothelialization and chances of less stent thrombosis. However, when I did this interdisciplinary meeting, the meeting was getting chaired by the transplant surgeon. And he said, "What is your problem?" I said, "This is my problem." And he said, "I don't care. I will do it on DAPT." So
Yeah,
now
they do
we
it.
are just doing it, and he's doing on DAPT, and
That's
no
correct.
problem.
Yeah.
Yeah.
Mhm.
So that's the dialogue that has to take place between the disciplines. Yep. Yep.
So once again, a wonderful session, interactive, informative, and most importantly, that is required for the disciplines other than cardiology to understand the need of interdisciplinary meeting, careful history taking, and assessment of the investigations so that we can make a surgery successful one. I'd like to take comments on Chowdhury Hafiz sir's lecture from Abdul Chowdhury sir. Are you there?
I think he's out. Yeah.
Okay.
Mhm.
So
I think we are time-wise good.
Abdul Jamil sir, are you there? Jamil sir, are you listening to me?
Yes,
Sir, please give your comment regarding the presentation.
it was excellent one. I enjoyed a lot and learned so many things. Different kinds of arrhythmia in patients who will undergo surgery. So it is always often challenging for a cardiologist to comment on and give management to these kind of patients. Thank you, Hafiz bhai.
Yeah, thank
Thank you,
you.
Tushar.
And also I learned about this myocarditis. We have now this Google search and all that. If you are suspicious, you have every information in the world in your hand. So check if you are suspecting, and this the newer chemotherapeutic agents and myocarditis, you can search it, and you can actually get some idea about this management also. But we reached out to the oncologist, and they told us how to manage this myocarditis in collaboration with the cardiomyopathy experts. And some of these cancer chemotherapy and myocarditis, the prognosis can be really universally
That's
bad.
right.
And
Mhm.
yeah,
Yes, and I want to add that the AI, it's like Gemini and Android and other, instantly they give us the information if I ask to them.
yeah. The only thing, Jamil bhai, that they will
Yeah.
not take the liability, because
Yeah.
they will give you info, and if you put a particular patient, they will deny to give you any recommendation. And if they give you information, the license is yours. Thank you. Thank you. All right.
Sir, last comment and the concluding remarks from our respected Rafique Ahmed sir.
Rafique bhai ka Ahsan na chale.
No, I think it's a fantastic lecture. One of the things that, I used to fight with the anesthesiologist or the surgeons, but patients die in the OR because the heart creates a problem. Otherwise, the patient will not die. So I think it's very, very important. And the pre-op evaluation is something, I think in Bangladesh, I don't know how much you're doing, but this is something that has to be emphasized, that evaluate the patient so that the anesthesiologist know exactly what to do during surgery. Somebody with EF of 20%, they hang a 1,000 milliliter of fluid and they give it. Patient goes into heart failure. So it's so important. So I think this is a broad topic that we need to keep coming back beyond the context of ECG group. But Hafiz, wonderful lecture. Thank you.
Thank you.
Thank you, sir. Thank
Maybe
you
in
for this.
future we can ask, and interdisciplinary meetings, we can ask one of the other discipline key opinion leader to come and join us, because
Yes.
that's the way to interact. So
we are going to arrange the next lecture session on 26th April, and there will be another fascinating discussion about troponin I and the ECG change and the ACS, the current concept, how to deal with it. As the matter you raised, the investigation troponin I creates a lot of confusion in AR among the physicians. So that will be discussed by our own Abdul sir in the coming 26th April. Till then, all the physicians who have patiently stayed with us, listened to the lecture, thank you all for staying with us. Hopefully, you will get benefited from the lectures, and hopefully, again, we'll meet on 26th April. Thank you all. And lastly, thank you, Bixingo Pharmaceuticals, for being the scientific partner in this program. And we'll meet again at 9:30 p.m. Thank you all.
All right. Thank you, Tushar. Thank you,
Thank
everybody.
you. Assalamu alaikum. Good
Thank
night.
you.